Again, welcome everyone. My name is McKenna Kresley, and I am the Communications and Marketing Manager at IDF, and I will be your moderator for this education event. Today, Dr. Maite de la Morena will be presenting on X-linked gammaglobulinemia. There will be time for questions at the end of Dr. de la Morena's presentation. Please submit any questions you have to the presenter in the Q&A section of the platform. Dr. Maite de la Morena is a professor of pediatrics and the medical director of clinical operations for the Division of Immunology at Seattle Children's Hospital and the University of Washington. In addition, she leads a partnership with the Department of State Health to provide follow-up for all infants identified by SCID newborn screening program for the state of Washington. She is an integral part of the non-malignant transplant program at Seattle Children's Hospital in collaboration with the faculty at the Seattle Cancer Care Alliance and the Fred Hutch Cancer Center. Her research spans both clinical and translational sciences by contributing to the phenotypic and molecular descriptions of novel PIDs, understanding the long-term clinical outcomes of patients with the X-linked form of hyper-IgM syndrome, and analyzing the microRNA expression patterns in children with 22q11 deletion DiGeorge syndrome to further understand the biology of human thymus. Welcome, Dr. de la Morena.
Thank you, McKenna. It's wonderful to be here, and thank you for your kind introduction. I have to, this is my second time presenting this. I presented a similar topic last year, and I'll give you some updates compared to last year's, and that sort of touched upon. I have to first apologize for my voice. I've been having a little bit of problems with my vocal cords, so it may sound a little crackly. Hopefully it will last for the rest of the talk and be able to answer questions later. I'm going to come off the video so as not to distract, and we'll get started here in a minute. So these are my conflicts of interest. I have received grant funding from the Hyper-IgM Foundation, and I'm a local PI and co-PI for for both a registry study and a study that looks at a new drug for the management of NLRP4 gain-of-function mutations. But none of these impacts my presentation today. This is the outlines. I'm going to talk about a little bit about the background of XLA, give you some definitions. We'll touch on some inheritance, talk about some treatments, and like I said before, I'll give you an update on two studies that I've been involved with. One is thanks to the USIDNet registry, and the other is health-related quality of life in patients with XLA, which was published this year. I'll give you a little bit of updates on COVID, how patients with XLA have handled COVID. I'll give you some interesting information on COVID vaccines in XLA patients, tell you a little bit about the IgG preparations and how that it impacts care. And then we'll close with some new opportunities in newborn screening and gene therapy for XLA. I always like to start with this slide. This is Colonel Bruton. He was a pediatrician at the Walter Reed in the 1950s. And at that time, the Walter Reed had acquired a new machine in the laboratory called the Thesalius machines. And what it did, it was identifying the different proteins in the blood. And so the top screen here, you can see the albumin and the different components of, and here are your gamma globulins, and these are the amount of gamma globulin in the blood. And you can measure the total proteins in the blood at the time with this new machine. And so it just so happened that Colonel Bruton was taking care of a child over the years who had had multiple infections and had 19 episodes of hospitalizations with either sepsis or some type of pneumococcal infections. Every single admission, the child would be able to recover thanks to the presence of the antibiotics. But what happened is that for reasons that are unclear, his serum ended up on this machine. And so what you can see here is that the gamma globulin fraction was completely absent, and the total number of gamma globulin here was absent. So Dr. Bruton, put 2 and 2 together and evaluated and recognized that the absence of gamma globulin was the contributor to these recurrent infections. And so what he did is, by replacing gamma globulin, that's when the first time gamma globulin was used, you would be able to get some IgG, and the number of infections were diminished. But it took almost 40 years later for the discovery of the cause of XLA, and this was really an exciting time. This was 1993. I was a fellow at the time, and it was and at our national meetings, these were the new discoveries. And what happened at the same time, a group in the United States and then a group in Europe published in the same month the discovery of a protein that was critical for the development of B cells. And these B cells were critical for the development of antibodies. And amongst the group in the United States was David Rawlings, who is my boss, and the person I have been able to join. And it's exciting to be part of this new era. He has dedicated his career to not only understanding XLA, but understanding its cause and the gene that is defective, and the functions of the protein that is defective. And he's ready to move forward with gene therapy. And I'll hold that thought because I'll share with you at the end of the talk. So what is XLA? XLA is an arrest in the development of B cells. And B cells are lymphocytes that are born in the bone marrow, and they follow a very rigorous and strict developmental process whereby they end up being this big globular cell called the plasma cell, and then releasing these 3 molecules, which are depicted here, which represent the antibodies. And these antibodies are either IgG, IgA, or IgM. And the protein that is critical for this process is called the Bruton's discovery tyrosine kinase, which is the function of that protein. And this protein is encoded by a gene called, also the same name, the Bruton's tyrosine kinase gene. So in the absence of, or in the setting of a defective BTK gene, you don't have this protein, and therefore you have no B lymphocytes or B cells, and you have very low or absent antibody levels. Now, we talked about the fact that it is X-linked, meaning it's inherited but through the X chromosome. As you all know, we all have 22 pairs of chromosomes, and then we have the XY and XX, which defines whether we are males or females. And so the defect, the BTK, is on the X chromosome. And so a male only has 1 X chromosome. So if that 1 X chromosome is defective, that is why the males are affected. But thanks to advancements in therapies, patients with XLA have now reached the adulthood and are now fathering children. And so while most of you understand the concept of X-linked disorder, I also wanted to stress the fact that patients that have XLA will be able to, their children, all of their male children will be healthy because they will be able to inherit either one of the X's from their mom and the Y chromosome from their dad, but this Y chromosome doesn't cause disease, whereas all of the female, all of the daughters are going to be carriers. So this is what you can see is that there's this skipping of a generation, and this path of a family will not have the gene, whereas this path of the family will have the gene. So gamma globulin has been instrumental in allowing patients with XLA to live beyond the childhood years, which was what was happening before. And these patients now have lived into their 50s, 60s, and 70s. And the age of XLA patients is really the age of gamma globulin, initially given as a sub-Q injection, then switched to an IM injection for in the 70s, which were very, very painful and really never able to achieve very high levels, then switched into in the late 70s and 80s to IV preparations. And then in the last 30 years, the creation of the subcutaneous products that have higher concentration so that you can be able to deliver a larger quantity subcutaneously, maintaining very good levels indeed. Whether patients receive gamma globulin infusions intravenously or whether they receive it subcutaneously is very dependent on personal preference. Studies after studies have shown that the effect is going to be the same and the control of infections will be the same as long as your IgG levels are adequate. Early identification of infections and initiation of prompt therapies is critical. And we'll talk about infections in patients with XLA in a little bit. There are some practitioners that use prophylactic antibiotics, and I'll explain that as well. And then what we have learned that is over time, the as infections are controlled and patients are living longer lives, they are, however, experiencing non-infectious complications, including inflammatory bowel disease and arthritis, and some of these autoimmune-like presentations that require additional therapies and to control these rare diseases. So in the next set of slides, I'm going to show you some data on the clinical features of this condition. And because in the absence of antibody, if you don't have enough B cells, you don't have enough antibodies. And if you don't have enough antibodies, then you're susceptible to bacterial and viral infection. And the reason is that the antibodies will stick to the walls of these bacteria and allow other cells of the immune system to eat up the bacteria and destroy it. But these infections affect many organs. They affect the lungs, the sinuses, the ears, the eyes, the skin, the joints, and including the brain. There are some unique features and susceptibilities to certain types of infections that are rare and that we are very unique to patients with XLA, and that is the Pseudomonas species, that can cause sepsis and bacteremia. And then for reasons that are not very clear, despite gamma globulin therapies, patients are very susceptible to certain types of viruses that can cause meningoencephalitis. I told you about as patients age and time goes by, gastrointestinal problems, not only caused by infections, but inflammation and inflammatory bowel disease can occur, arthritis, and in some cases, malignancy. These are data from a Herculean effort that was taken on by Kate Sullivan, where a group of 40 centers from around the world got together to collect the data on patients with XLA. And they published their data for over 700 plus patients. And what was very striking is, independent of where you lived around the world, these same similar bacterial infections causing sinopulmonary and upper respiratory and lower respiratory infections were occurring. However, there were some uniqueness depending on where you lived and what types of vaccination protocols were available. And so patients who lived in countries where the polio inactivated polio vaccine, live attenuated polio vaccine was still present, were being recognized as having polio, which is not the case in other countries like in North America and Europe. And there are regional differences in terms of survival. So if you've looked at survival past the age of 20 years, if you look, the majority of countries in the Americas, North and South America, are very similar in terms of survival, with the worst outcomes in patients from Africa and Asia. The three types of complications that we've talked about, enteroviral meningoencephalitis, inflammatory bowel disease, and arthritis, were noted at different frequencies depending on where you lived, and whether how much one could truly identify the disease. So in an effort to see how we are doing here in this country and in North America, we partnered with the United States Immunodeficiency Network, or USIDNet, which you may have heard about. And the USIDNet is a program of the Immune Deficiency Foundation that is supported by a collaborative agreement with the National Institutes of Health, and specifically the National Institute of Allergy and Infectious Disease. And it has been spearheaded by Kate Sullivan and Charlotte Cunningham-Rundles and others. And that has really been critical in our understanding of patients with rare conditions. And specifically, the last time overall analysis of this registry was done 15 years ago, although in the interim, there have been many studies that have been published on XLA looking at unique features of the disease. For example, the development of autoimmunities that Dr. Hernandez Trujillo published, and more recently, looking at specific infections. But the purpose of our inquiry was to see how have we done in the last 15 years. And so we collected data on 240 patients. And what we saw is that the number of the family history was increased from 40 to 60% of patients, suggesting now that there are more family members being identified. And this is important because family members identified are being identified earlier and younger, and therapies are started sooner. In addition, about 95% of these patients are now diagnosed from a molecular standpoint and confirmed that the defect is in the BTK gene. And while the age at disease onset really hasn't changed, but that makes sense, right? Because if you think about it, we all, at the time of birth, receive maternal antibodies that cross the placenta. And so at the time of birth, the baby has all the antibodies it needs from its mom. However, these antibodies disappear. And while a child that is has no defect will have all of the machinery to make antibodies, children with the XLA will not have that machinery. And so as the maternal antibodies disappear, which is between 3 months and a year, that's when the infections start popping up. The good news is that the age at diagnosis has come down. So before we used to, these patients were diagnosed between 4 and 5 years of age after a series of infections. And now today, the number of the age at diagnosis has significantly decreased. Amongst the North American patients, 92% of patients were on gamma globulin therapy, which is concerning. It's good, but concerning because that means 8% of patients were not receiving any therapies. About a quarter of patients were on prophylactic antibiotics, and this is not totally outside the norm in the sense that there are practitioners that encourage prophylactic antibiotics and others that don't. There's not a strict guidelines that suggest that this is the way to go. About 8% of patients were taking other immunomodulatory therapies, and that was primarily for the control of inflammatory bowel disease and arthritis. Interestingly, many patients, almost over a third of patients, were requiring some type of surgery, and quite amazingly, appendectomies were much higher amongst patients with XLA than in the general population. In this cohort of 240 patients, 2 had undergone a stem cell transplant, and 2 had undergone a liver transplant. One of the patients who had undergone a bone marrow transplant had passed away, and the other is alive, and both of the patients with liver transplantation had survived. So one of the questions that we wanted to ask was, how are the different organs involved in patients with XLA? How does it change? Are we doing better with the therapies, and what happens after you start the therapies? And so this is a graph that looks at organ and system involvement before and after diagnosis of XLA. So you can see in red is before the diagnosis and blue is after the diagnosis. And on the y-axis are the different organ and respiratory, gastrointestinal, neurological, musculoskeletal, dermatologic, etc. And what you can see is that the respiratory tract, it remains the most important organ involved before the diagnosis, followed by the gastrointestinal and neurologic and musculoskeletal. Whereas after diagnosis, over almost 50% of patients are still having respiratory, gastrointestinal, and neurologic problems. If you look at the infection rates before and after, this is on the right side is the types of infections. And what you can see here in red are before diagnosis, and in blue is after diagnosis. Before diagnosis, the majority of patients come to medical attention because of the development of pneumonia. After that, they have ear infections and sinus infections. Once the diagnosis is established, pneumonia continued, but now sinus infections, ear infections, and pneumonia, all respiratory organs involvement continue despite therapies, including gamma globulin therapy and despite antibiotic therapies. Now, if you look at the types of infection here and you look at the trends, in other words, are there any types of infections that decrease once the diagnosis is made? And the answer is yes. Meningitis and bacteremia and sepsis, in other words, those that cause early mortality in decrease. Doesn't mean that they're absent, but they certainly are decreased compared to after you're diagnosed. After diagnosis, you continue with sinus infection, ear infections, conjunctivitis, very common, and sometimes creates a significant problem, skin and pneumonias. So I'm going to switch gears a little bit, and I want to talk about health-related quality of life. You know, when we see patients in the office, the first thing we ask is, how are things going? And the answer is, for the most part, is, oh, things are going pretty well. Given the data that I just shared with you, I really was interested in understanding the self-perceived health status of patients with XLA. And I wanted to examine the associations among the clinical characteristics, the treatment experience, and quality of life. And so we embarked in this study, again, in collaboration with the Immune Deficiency Foundation. And this is a study that is a retrospective study of 91 patients with XLA. There were 58 adults and 33 children. And the data was extracted from the Immune Deficiency Foundation National Patient Survey and the National Immunoglobulin Treatment Experience and Preference Surveys. And these are direct patient surveys that include anywhere between 46 and 68 different questions. And they evaluate the health and the well-being amongst patients in North America with PID, and in particular, we selected patients with XLA. So what we found is that amongst adult patients, the physical scores of health, the scores that define your physical health, was just slightly below the general population, but it really didn't reach any statistical significance. However, and you can see on this slide, if you look on the left side are your physical composite scores of domains, and on the x-axis are the current conditions. So patients who have more than one condition, in other words, if you start having issues with sinusitis and conjunctivitis, or you may have GI disease and respiratory. So when you start having more than two conditions, what you see is that there's a statistical significantly drop in your physical perception and in terms of physical domains of health. And similarly, if you look at the mental composite score, in other words, your mental health well-being, the presence of anxiety, fatigue, depression, also decreases the more chronic conditions patients have. Additionally, hospitalizations impacted significantly the physical domains of health. So being hospitalized really impacted patients. It did not impact the mental domains of health. And if we look at insurance and how it impacts health-related quality of life, what you can see is that it doesn't seem to impact the physical domain. In other words, patients are physically stable and well. And here on the left is your public or no insurance. And here on the right is the private insurance. And yet, when you look at the mental domains of health and how that is impacting patients' mental health, those patients with public and no insurance really fared worse than those with public insurance, suggesting a discrepancy here and an equity question that needs to be addressed. Okay, I'm going to switch gears. I'm going to tell you a little bit about COVID-19 and what's happened. And the reality is that when the pandemic hit, there were a number of publications very early on that stressed the fact that in general, most of the patients with the XLA, even though they were small series, handled the infection well. And then since then, there have been over 20 different publications that have really outlined differences. And the reality is that in most patients handle the infection, but there are patients who continue to have significantly worse outcomes. And certainly those that may have the underlying the underlying comorbidities associated with poor outcomes. So this is a continuing investigation, but something that people need to be mindful of, in that we're not out of the pandemic yet, and we need to be still cautious, in my opinion. Now, I wanted to share two interesting observations. And the first, and I think is very exciting, is what was the response of the patients with XLA to the current messenger RNA vaccines? And this is very important because the purpose of one of the critical purposes of vaccines is the production of specific antibodies that can neutralize this virus. And so there's a paper that just came out in May of this past year. A large group of Dutch investigators looked at over 400 patients with inborn errors of immunity, many of them with difficulties making antibodies. I was able to extract the data on 19 patients with XLA. And what they found was that most patients didn't make antibodies, which is expected. There were, however, 3 that did. And that just speaks to there is variability amongst patients with XLA, and that some patients may have some few B cells and some amount of antibody that allows them to make antibodies. But the interesting thing was that all patients were able to mount specific responses from their T cells. And these T cells remembered having seen that. And that's a critical part. Unfortunately, we do have the ability to check for antibodies, but we don't have the ability to check for these specific T cell responses in a clinical setting. So I can't take any of my XLA patients and say, okay, well, we know we can't make antibodies, but let's look to see if your T cell responses are there. And there's not a standardized approach to looking at that today. More recently, this past month, was an excellent paper published in Immunity, which looked again at these patients with XLA very in-depth to look at this T cell responses. And why do we care? Because T cells, we know that antibodies are important to, B cells are important to make antibodies, but T cells are critical because they talk to B cells and tell them to make antibodies. And they also are capable of directing the show and targeting specific cells that have been infected by viruses and killing them. So the role of T cells is critical. And what they found, these investigators, is that all of the patients with XLA mounted an appropriate response. And all of them, that T cell response was present still 6 months later. What about IgG preparations? We know that, since the time that it takes between somebody donating plasma and that plasma ending up being in somebody's arm, as in the form of IgG preparation, sub-Q or IV, it's almost 2 years. So the question is, what has happened through the pandemic? The good news is that I've not heard of any shortages thus far, and I have not had any of my patients experience difficulties in getting gamma globulin preparation. There's a study that looked specifically at the presence of antibodies to COVID. And as more and more individuals are vaccinated and donate, then the expectation is that the gamma globulin preparations may have antibodies to COVID. And the reality is that there is a lot of variability from batch to batch. And when looking at amongst patients specifically with XLA, In this particular study, there were four patients with XLA. All 3 out of the 4 got COVID, but all of them had been vaccinated and all of them had mild symptoms. So to me, what this tells me is that, number one, we should continue to encourage vaccination for patients with XLA, even though we know that the antibody response is impaired. But we think that the T cell response may be protective. We don't have that proof yet, and that will require some time of seeing how patients who have with XLA having had the vaccine versus those who have not had the vaccine and how the outcomes. It's going to be a little bit difficult and tricky given that all patients are on gamma-globulin, but only long-term follow-up is going to be able to answer the question of how protective these T cell responses are for patients. And then let me switch gears about newborn screening. So I told you that as time goes by, patients may have organ damage and in fact, in particular, lung organ damage. And that lung organ damage impacts morbidity and mortality over time. We know that the current prevalence of XLA is between 1 in 100,000 to 1 in 200,000 or so. And a recent study that was published by Kate Sullivan and Charlotte Cunningham-Rundles, who you may have heard speak earlier yesterday, looked at what are the predictors of poor outcome and could early diagnosis alter the disease course? And in fact, what they found is by looking at the US IDNet registry as well. And what they found is that compared to those patients who had died, the patients that were living had been diagnosed much earlier. Second, that the patients that were diagnosed earlier had less lower respiratory tract infections and less complications in terms of a chronic lung disease. And patients with a family history of XLA were tended to be diagnosed earlier and started therapies earlier. So the hypothesis is that early diagnosis might alter the disease course. And the question is, can you make the diagnosis the same way we're screening for many conditions that have therapies, because XLA is a condition that has a therapy, can we identify babies with XLA who, for all purposes, when they're born, they're perfectly healthy? And we do have an analyte right now, they're called CREX, which stands for kappa deleting rearrangement excision circles. That's a mouthful, but the bottom line is what happens is, as I showed you, as the B cells develop, over time, there are little circles and pieces of DNA that are looped out as the B cells progress in development. And you can measure that, and it's a marker of these B cells being new B cells coming out of the bone marrow. The challenge is that we are doing many different newborn screening and sort of trying to get everything from that one single blood dried spot might be a little bit challenging. However, it's exciting to know that there are certain countries like Sweden and Switzerland and Poland and Japan, Iran, Brazil, and Australia who are already doing this. And so we will need to see need to develop these long-term follow-ups to determine the clinical utility of such early detection, which was clearly established for severe combined immune deficiency, but is not clearly established for XLA. So more to come on that. And I think this is an exciting new area. And then finally, gene therapy. So I told you that David Rawlings has really been pioneering a lot of the work on XLA, and it's been a long-term effort in the bench to the bedside and from the bedside to the bench. So he was part of the group that discovered BTK as the as the cause of XLA, and then has spent over the last 30 years or so really understanding the key functions of BTK and developing a gene therapy strategy for XLA, to the point that the hope is that in the next couple of years, we'll start the first in-human phase 1/2 clinical trials. And basically, the concept is very simple, and that is you collect these hematopoietic stem cells from an affected individual, you isolate them, then you correct them and give them either the gene that is missing, or you can correct the gene inside the cell. And then once this gene is corrected, you infuse them back. And so it sounds very simple. There's a lot of nuances and difficulties here. And one of the difficulties is getting these stem cells in a quiet state that have not progressed through the differentiation process to become whatever cell in the blood they need. And so getting them very early on is challenging. But I think in the next, this is going to be the next therapies that we will be seeing in the next 10, 20 years. So in closing, there are challenges that we need to address. And I think one of the most important ones is access to gamma globulin therapy throughout a patient's lifetime. And one of the things that keeps me up at night many times is as my patients transition to the adult care and the potential loss of insurance and how that financial burden will impact them. People have had patients who have had to sell their homes, and it can be very distressing. Understanding what is the right long-term monitoring and how can we prevent the pulmonary complication, and how can we best manage some of these non-infectious complications, inflammatory bowel disease in particular, which really doesn't respond to us as the standard patients with inflammatory bowel disease. We need to recognize these enteroviral infections and understand this process better. We don't really understand it well. And we really need to provide the psychological support and the equity for all of our patients. And with that, I'll stop, and I'm happy to take questions.
Thank you so much, Dr. De La Morena, for sharing that wonderful information on XLA for our community. We do only have about 2 minutes left until this session. So if you do have a question, we might be able to answer one of them. Right now, there are no questions in the chat. But if you do have a question, please throw it in the chat. We are having some technical difficulties for our Q&A, so make sure you put it in the chat section if you do. We'll wait about a minute to see if any questions come in, but in the meantime, I would love to tell you, Dr. La Morena, that research was amazing, and it's so great to see that the diagnosis period is becoming earlier and earlier at 2 years of age right now, instead of that 4 years old. Do you think that there's any reason for that? Is it just because of broader awareness within the medical community, or what would you say is causing that?
Yeah, I think that's a great question, and I think the IDF is one of the reasons we can think about, be grateful for, because of the patient awareness and advocacy and education, and those are the key. Those have been key instruments in trying to have patients and not only that, but the practitioners out in the community understand that this is not a diagnosis that is difficult to make. You just need to check a set of immunoglobulins and think about it. And once that is thought about, then you can make the diagnosis quickly. we live in an antibiotic era, so the child that comes with the recurrent ear infections and responds nicely to antibiotics is very appropriate. The young toddler that's in daycare is going to have more respiratory and more ear infections, but being able to identify which one of those patients are the ones that are coming too frequently, and whenever the thought comes to mind, the diagnosis should be pursued. And the cost for just a set of immunoglobulins is not that high. So there's no, and you don't need to be an immunologist to collect a set of immunoglobulins. You can call us when you get the results, but certainly it's critical to do the test.
Right. Thank you so much for answering that. So our time together has come to an end. So if you do have any questions that we couldn't answer for you today, or you're thinking later, oh, I should have asked this, we encourage you to go to Ask IDF and ask any questions that you may have, and our staff will reach out to Dr. De La Morena to get your questions answered, or anyone else in the field, to make sure you're getting the accuracy and the details that you need. So thank you so much. It has been an honor to have you join us today. And for those interested in learning more about XLA, please visit the XLA Life booth in the virtual exhibit hall. And I hope you enjoy the rest of the conference, everyone.
Thank you.